Hey, it's Elge and Simple Lines Anatomy. Whoa! And this is structural analysis of a curve back, part two. So, in the last one, we talked about how we were looking at the back, what we could see just from the visual inspection, where that would kind of lead us to, what kind of things we were interested in investigating further, and what we kind of wanted to make sense of based on what the patient had initially told us. We mentioned the symptoms only at the end, and we thought that was, a good way of doing it, just to make sense out of the stuff. Understand what you see first, and then start to compute in the symptoms in this case. There's lots of different ways of doing it. This is not the only one, of course, but this is just a way of doing a good visual assessment followed by an anatomical proportional relationship. A nice disclaimer again. I'm not a doctor. None of this is real medical advice. None of these are real medical diagnoses. Please consult a medical physician before making any decisions about your life, about anything really. And it's really all for educational and artistic purposes. Okay, so let's look at these symptoms again. Back pain, number one. Symptom number one. Yeah, you think? Oh, okay. So that's a given. That's a given. You can't have extreme curvatures like this seen in these two pictures. This one I think is probably the best view of it. But having this kind of a round through the spine here, this kind of a round, we must have some significant lengthening of our erector muscles in this case. We're looking at it at this level, longissimus spinalis. You'd probably be into some semispinalis, maybe even splenius, a little bit if we're getting up as high as T6. In any case, with that comes pain, of course, comes quite a bit of pain because it's in a position of strain. Now, we're going to relate that to some other positional things, but definitely we can start to say at least that there's more than enough warranted for a case of just pain somewhere in the back. The lumbar spine area too, for sure, because it's got that kind of a round, because it's got that kind of a unnatural flexion to it. I would say, yeah, easily back pains. Pretty good. Okay, now let's talk about the mechanism of action. So there was an improper lift of a 20-kilogram tank. So it was some kind of a tank holding something. Kilograms actually mean Canadian gallons for the Americans in the group. And if you wonder why it's K, it's because in Canada we're dual language. So that's the French version of spelling Canada with a K. Okay, so anyways. Now, I think this probably was the mechanism of action here. Notice the next 2 points. Lots of computer time, pain while working in kitchen. We're going to explain that. The computer time is relevant, but I think there was a trauma behind this. And the reason why I think there's a trauma behind this is because it's an extreme curve. So this fellow here is sort of modeling what's going on. So it was said to be an improper lift. And the follower that sent this to us, the one follower who wanted us to work this all up structurally, said he felt his spine curve as it went. So think about how the movement and the forces are being carried. So he's lifting something. There's something over here, a tank of some kind. Let's say it's a propane tank. And it is pulling this way. Its weight, which is significant, is pulling this way. And it's, in fact, often more significant when you're not expecting it to be heavy. So it can become a very jarring motion. So ultimately it ends up, because around here the thoracic spine is curved this way, it will pull on a certain area. Understand that this weight, this force is going through this entire arm here, and the entire arm pulls from ulna to humerus, into the scapula, and from the scapula it pulls into the spine and ribcage, and that's through the trapezius muscle here, for instance. And then of course we could talk about the rhomboids too, a little bit deeper, but the rhomboids for sure will be in there. Yeah, you could throw in levator scapula if you want, but let's not get too technical. So there's some connections in there. So from those arms, it's going right into that thorax. It's not really going to go into the neck. The head can get jarred around for sure, but more than likely it's going to go into thorax because that's the more weight-bearing structure. Remember, it has these ribs to reinforce it all. It's got the ribs for a reason, makes it a stronger structure. until it's not. So once we load that weight on the thorax, a significant and I'll say fast weight, like a quickly delivered weight, it tends to compress it like this. So the weight of it being pulled down, the weight of it being pulled like this, again, will tend to pull down like that on the thorax as in the moment of leverage. And so it compresses straight down on the thorax. Now, here's the thing. It's going to summate, those forces will summate, and they're going to pull to a point at about here. That's where most of the load will be taken on. From that point here, so it's going to be from that point here, what is supposed to happen is that we've got powerful muscles of the erector spinae group, so that will pull and stabilize the spine, and they will reverse this downward pull. They will pull in opposition, and then from there the pelvis will start to do the opposite, because the pelvis will be pulled that way. And so the pelvis will use, say, rectus femoris, and then it will use the psoas muscle to counterbalance this force. And we can work it all the way down into the foot, but we don't really need to do that. So we've got all these muscles to try and make that happen. Unless it doesn't. That's the thing. It works until it doesn't work. It's always the case. So in this case, what I'm assuming happened, simply because the angle of the spine here, the angle that it's sitting at, and because of the mechanism, the 20 kilogram tank, that those muscles, it was either too fast or there was something going on where the things failed to fire, it failed to retain structural integrity, and something slid out of place. It bowed like that, and got pushed hard back like this. At the moment the force of this 20 kilogram tank yanked on the arm to the thorax, and one spot in particular gave way and allowed for a full flexion to occur. And I say this simply because I can see where the apex of this curve is, because we've got like a flat, just as we explained in the last video. We've got a hard flexion, like a very developed flexion here. So that means the vertebrae in this particular position are very close together. I'm not going to say anything like that. I don't think this is a fracture. I don't think this is a disc herniation. It's not my job even to say any of that. That's for a doctor or a radiologist and, a good CT machine, or an MRI preferably. But we don't have that luxury. I'm a million miles away and on a computer with a bunch of cell phone pictures. So we're doing what we can with this. So understand that the position of this, they have to be pretty approximated. They have to have come relatively close together. And this does not normally happen. This is the body does everything it can to avoid this from happening, because we've got a very strong disc in this space. So something is really shortened up here, and it takes a lot. Remember, not only do we have muscles in the area, but locally we have smaller muscles. There we go, throwing a few smaller muscles, but we've got very strong ligaments. Not enough is mentioned about the ligaments. In particular, we have the ligament of flavum in the back here. I just want to make mention of that. And red, blue, yellow, cool. The ligament of flavum, which is a very bouncy ligament. It's a spring-like ligament. It's got a yellow quality to it, of all things, and it means it can bounce back rapidly on the posterior side of the spine. It's supposed to take on these forces and defer it nicely down the spine, but that didn't happen in this case. So I'm going to say that's the bigger problem. And a lot of the other things we can kind of build off that. We can say are secondary to this. Okay, let me peel off a few of these spots just to clear it up. You get the idea. Okay, so now we can start to make sense of the other things. So with lots of computer time, this thing here, the lots of computer time is meaningful, because they indicated that they spent a lot of time last year. They noted that they spend a lot of time on the computer in the previous year. And that's saying something, because the standard for what's a lot of computer time now is very high, very, very high. And so this tends to continue the fold. So it's very normal in a seated position. Get a small pen for this one. It's very normal for a seated position that you are never good. I'll say that. How about just not good at all, ever? And so in a seated position on a chair, you're kind of in one or two spots. Yeah, I remember doing a little mini article on this some time ago, and it tends to be either the person is here and bent way far forward, arms on the keyboard, legs like so. Or we have a second option. The pelvis is way far back, and we curve our spine heavily like this in a very restful position, and we have our arms on the keyboard out here. Neither is good, understand. If you spend a lot of time on the computer typing away there, you're probably going to be doing that at one point or another. And both of them ultimately have this C shape that happens in the spine. Doesn't matter which side you do it to, forward pelvis, backwards pelvis, could go either way. You will get this same kind of curvature to the spine. And this would not only increase the thoracic curvature here, would increase that big flex point, but it would start to fold out the lumbar spine. And we do see that. Again, we have a very flat, we'll say flexed, I'm going to say flexed right here, flexed lumbar spine with a flattened part here. So if this is, like 10, 11, 12, I'm going to say 10, 11, 12, L1, L2, kind of into that region, and definitely L4, L5, that's for sure been flattened. And the seated position explains that. But I would say more than likely what has also happened, this part here has influenced how he's been sitting. Because if this is very flexed in here, that's very flexed, he's going to find it a lot more comfortable being very flexed here, and so he'll flex this more as well. If it's stuck there, and it's been long enough, because it's been, over a year, it's worth mentioning that is the preferable shape of the spine for that juncture in time. All right, so nothing wrong with being on a computer. You got to sit up straight, and you got to get up and move around frequently. Now, the pain working in the kitchen, actually, that makes a fair amount of sense, because there's something about that exacerbates the existing pattern. So we mentioned this flexion here, and I'm going to throw this one back in. We mentioned this flat and flexion look here. Well, when you're working in the kitchen, typically the sink will be in and around here. Let's say that's your sink, and your pelvis is roughly at this height. And this seems to be a fairly tall guy. To me, skinny too, fairly tall. Anyways, so you're working away, and you've got your head looking down. Your eyesight is here. You're doing your dishes, make your wife happy, good choice. And you will be largely flexed in this position, because there's no way of really angling. The ideal thing, perfect ergonomics for working in a sink, would mean the sink would have to be here somehow, which would be difficult to do. Or you could angle your sink like a drawing table, but the only issue with that is that the water would spill out, and that's a really poorly designed sink. So that's impossible. So there's not really many good ways to work at a sink, unless you have crazy strong back muscles, but no one does. So there's your scapula, and you're working away, you're washing your dishes. And the thing about this general position, we actually take on that C shape again. We take on that C shape, but we have our head further forward than it needs to be, further forward, and so the weight of gravity is a little more significant. In our chair analogy, at least these 2 points, the chair supported this point and the pelvis, and so it took on a lot of the weight. But the reason why we're getting pain when we're doing the dishes is because we've got a very exaggerated curve through here and an exaggerated flexion curve through here, and then the weight of the body is just yanking down on that whole spine. It's doing that. It's like summate all that together, and it's doing something to this effect. I can do better than that. Come on. Different color. Yellow. There we go. It's doing something to this effect. And so when that happens, the stretch on those spinal muscles, the stretch of all this is getting quite extreme. Those spinal muscles are much more elongated than they should be. It's much more elongated than they're used to. So they go like this, as well as the back lengthens, so do the spinal muscles. And it will be at the pinch points here. It'll be especially at these pinch points here and here, or in our side view, in our poorly drawn side view, around here and around here. These are the most lengthened points, and so when we add general lengthening to an area, it isolates on those points because they're already at their load limit. These two guys here are already basically at the point of strain. It just takes a tiny little bit more, and boom, suddenly it's sparking off in pain. Tiny little bit more flexion, which adds the tiniest bit more strain, and it was already ready to go. Like it was right there. And now you've set it off by a seemingly innocuous action like doing the dishes, which is something you need to do. You got to do the dishes. Okay, so that to me makes sense. All right, now let's talk about how we're going to deal with these in groups. That's group number one. With the back pain and getting rid of this, that's the important thing, right? We want to talk about how to get rid of this, and you'll need, if you ever have anything like this person in particular, we've spoken, and it's important that you see someone who really knows what they're doing with body work, with exercise therapy, preferably both, and a few people. You got to find the right person for you. But to get this in this position, it takes myofascia. There's joint positions, of course, there's nerves. These are all important things, but you have to understand the stuff that's holding it is the connective tissue. There has to be some kind of a contraction, and we should get rid of that first. So to hold it in this position, doesn't matter what caused it. We can talk to the cows come home. That's an expression for those of you outside North America. A long time, that's what that means. Anyways, we can talk all we want about the mechanism of action. It doesn't tell us everything about how to get rid of it. It was a yanking motion, great. But here's the thing. It's been put in that motion. Now what's holding it? So let's work from the outside in. We have got a shortened front because we have a long back. If it's longer here, it has to go shorter here. That's how that works. So working it from front to back is actually quite easy. What's on the front in that long axis? What's on the front in the long anterior tissues? Really, really easy. We can look I don't even know if I have a picture of the front. That's fine. But we've got pec major going around that way. Pec minor, which is somewhere around here. We've certainly got our rectus abdominis, like so. Oh, I can do that one. Hold on. Where'd that get to? Yeah, rectus abdominis, like that. And that is very much a vertically oriented thing. And then we could also mention the psoas. I would say the psoas becomes a flexor at certain angles. Wrote that up previously. Don't worry about it. And then the obliques too, to some extent, should be mentioned because they do pull into a shortened position. So those are just a few. Of course, the general fascia of the region, the overlying fascia of the muscles, we should consider that. We can't free up this motion. We can't free up the decompressive, the extension or neutralization motion without first clearing all that up. Now, when we get more local to the spine, we can talk about the ribs. I'm going to just gloss over this. This won't be too detailed. But there will be a vertebral body attachment to that rib. Nice TVP attachment. Didn't do a great job of that, but that's okay. There's some ribs there, and they're going to be kind of pushed together as well. So we should consider dealing with those too. They really do have to do that. And then when we get more local to the vertebrae itself, don't forget about that anterior longitudinal ligament. Now, you can't get in there without a scalpel, but you can catch it by position. We could say the same thing about the lumbar spine in this particular area, dealing with that anterior longitudinal ligament, and pretty much the same muscles in general. So if you wanted to effectively deal with this condition, if you were working in the manual therapy field or exercise therapy field, that is what I think should be dealt with to help free up this significantly flexed position here, this significantly flexed position. And only then are you likely to see a resolution of that, and then the pain that is simply a product of the strain in the region. That's what I think. Okay, so that was section 1. Now, next one's an interesting part. So this here, when standing, cannot feel the weight of the right leg. That's cool. I think that's a neat, I'll say a neat thing. But it points us in a direction. And I didn't spend a ton of time on this in the last video because I needed to have the symptoms up to start making some real guesses. And again, a lot of this is just guessing. It's guesswork. It's semi-educated at best, but it is just guesswork because I'm incapable of actually doing proper palpation and proper motion testing. Those are, in this field, those are the true gold standards. If you don't have that, then it is guesswork. But I think I'm doing all right, and I'm just going to go with it. Hopefully we'll learn something. I'm going to make mistakes, guaranteed. I admit it, and I'm fine with it. That's how you learn. All right, so when standing, can't feel the weight of the right leg. And there's pain in the right knee. Those are two important things. Now, when we say cannot feel, that was what was written. That was what was contained in the explanation. It's telling us something. There's been some kind of sensory loss. That is a bit of a red flag. To my knowledge, there's been medical involvement, and they've screened this patient. Great. I don't need, again, I'm not in direct contact with this person. If I was in a clinical setting, oh yeah, like, yeah, get that looked at. That's a MRI, CT scan, preferably. But here we are on the internet. So anyways, I would be thinking nerves, or at the very least some kind of altered sensation. And for me, I tend to go to the root of the nerves when that's the case. And we already talked a bit about like L4, L5, and we briefly mentioned the sacrum. I'm just going to change that color. Nice light blue. There we go. That's one of my favorites. Blue and pink, light blue and pink, just a fantastic. You know, normally it's not my favorite colors, but some reason in this program, gorgeous stuff. There we go. So there's throwing a sacrum there just for clarity's sake. Grab those horns in there. You get the picture, anyways. So there's a sacrum. That's not exactly proportional. Now understand that the nerve roots in the leg, we'll throw it in the right side because you mentioned the right side. So there's like L4 nerve. It's coming down the front, L5 nerve, and there's your, hit it into S1. Oh, I got that backwards. Okay, L3, L4, L5, and then we start to get into S1 and 2, and those, of course, are coming off the front of the sacrum, and about as low as S3. Depends on the book you're reading, but whatever, a few segments off. I'm not going to worry about that personally. Who can memorize all that, eh? I heard there's a great app program that helps that. Don't worry about that. Okay, so, anyways, this is starting to tell us something. So he can't feel the weight of the right leg, so there's been some kind of sensory interference. Now, the bad stuff would be, disc herniation or bulge in this area. It's come out of that side. That would be bad. It could be that we've got some kind of change in position of the sacrum, on the other hand. It doesn't all have to be disc bulges. It could be a sliced nerve too. I think that's very unlikely. I'll say that, but I don't think that's it at all. It's very, very unlikely because there would be an absolute sensory loss. I don't know. Again, this is only guesses. Medical doctors need to be involved for determining that kind of stuff. So I'm going to guess we've had some more sensory changes too, because we've got a hip joint here. That the nerves in the area, and it could be, I've drawn in the sciatic, but it could certainly be superior and inferior gluteal. Those guys are in there. We've got like nerve to obturator internus, somewhere around there. There we go. We'll throw that in like that. But the sciatic nerve too. And these innervate a few really important structures. One of which is, I'm going to draw it on the left side just for clarity. There's the sacroiliac joint, and that's got a lot of large ligaments on the back of it, and same with the hip. The hip has a dense capsule that holds it in place, and these are important structures that require a lot of sensation, but at the same time, because of their dense fibrous areas, can confuse the system if they're off. And I don't know exactly what the issue is, but based on some of the positions I've seen, I think we mentioned in the last video that we were theorizing that we had some kind of a posterior sacrum. I'm going to throw on top of that now, because of we've added some kind of a symptom. We've got a funny position to the sacrum that I believe the osteopathic groups, they call it a shear, but it's just a twist. It's gone and twisted on us. It's done some kind of a this thing. It's done. Let me get a little closer there. It's done a turn that way, or it could be like a forward twist like that. They call these different things in any case. So it's coming forwards or backwards at us with a bit of a twist. When we start to do that, when we start to change the position of the sacrum, say it jams forward like that, well, these ligaments start to get stretched out, and then the shared muscles between them, whether it's like, piriformis coming around on that guy. Where's that piriformis? There we go. Close enough. Oh, not even close. I'm getting there. There we go. Piriformis coming around here. And then we've got, like, the other ones. Pelvic diaphragm to some extent, because that does have the sciatic nerve partially going through. It has the obturator too, incidentally. And then the quadratus femoris, which is in around. There we go. Quadratus femoris, obturator internus, obturator externus. You get the idea. This is getting too messy, so I'm going to get rid of some of this. But that changes the strain and the pull in the area. And that means we get a whole bunch of extra feedback, whole bunch of extra nervous feedback into the system. And though it's not been absolutely proven, but irritating a nerve over a long period of time can confuse it. So we're talking about some kind of a sensory loss in the area. Cannot feel the weight of the right leg, but it's not a numbness. Usually the patient can distinguish between the two. Usually they can say, okay, it's I've totally lost sensation, or it's a horrific burning pain, or something else. I've lost motor power. That's a bigger problem. Anyways, now the pain in the right knee. Let's cover that. So the pain in the right knee too is, I guess, a loading problem. Like, this is all a mess. And we know we've got, because of this too, we know we've got something funny. The big flexion will drive the whole body forward as it's done here, and it will change the angulation of the knees. Now, he's bending here to compensate, just so we're clear. But if we take a look at that other picture, scrolling around like a madman, there we go, zoom, zoom, zoom. Okay, so this is the right side, just so we're clear. That's right, that's left. More for me than it is for you. Look at the way, we talked about this before, but just look at the way this is starting to collapse in on us. Now the twist in the pelvis again becomes obvious. That side's a little fuller and that side's a little more like that. I'm exaggerating these things, but that's the whole point. And then we could probably say that there's a twist running through there too. I think that does mirror what we're theorizing in the sacrum. I don't want to say which side it's to, but definitely some kind of a rotation has come through. Understand that if the sacrum is twisted, the sacrum's all the way back here, and those innominate, the ilium, ischium, pubis, they have to come all the way forward, and they form, you can do that one better, there we go, they form a pubic symphysis in the front. And so you can't really twist this thing up. I find it kind of bugs me when people talk about this, but you can't twist the sacrum up without having some kind of effect on the pubic symphysis too, and really the entire pelvis. They're all, a unified piece. So something that happens here, you should see something going on here. So that whole pelvis should end up being, quite rotated. And that's what I'm seeing in there. Something worth mentioning. So again, theoretically, until there's palpation, until you can actually motion test and move that structure around, who really knows? However, both knees definitely have this like inward look. They both seem to be coming in just a little bit. And I can say that for sure, even though he's wearing pants, I can say it for sure because this angle here is also off. This angle is also slightly off. It's coming out like that. And then it starts to even show up even worse. The feet are like now the expression of this off-center weight, and we've got a flattening arch. It's not totally gone at this point, but a flattening arch. When we start to do that to the leg, when we start to really mess around with this position, if that's the femur coming down and the tibia underneath, for instance, and there's the medial malleolus, lateral malleolus, we've got a bit of a side shift happening. So it's being pushed to the side like so, and that means any of the ligaments in between, and there are quite a few. I mean, ACL is going to be your bigger one, but then MCL and LCL to some extent, PCL, we throw that in there, and any of the connective tissues around the area, they're going to be on some strain and stretch, so it's reasonable. Now, I would say, realistically, both knees should be hurting at one point or another. why they're feeling it more on the right than the left. It's just how they use it, kind of thing, you know. It's just what they've been doing with it will largely dictate that, because maybe they're dominant with their right foot in some way in an activity they take on regularly. So that would be a guess again in this case, but that's my guess just based on everything I'm seeing so far. So that knee's coming into that side, it's straining all this in here. It's not happy, it's in pain. The ankle, the foot too, you know, there's going to be problems. Before this, I didn't show these pictures, but I was also sent close-up shots of the foot, of the arch collapse. And again, I think that's obvious, just because what ends up happening is, because the weight is borne more to the inside as these knees come in, it ends up being that this part of the arch is heavily pushed on. It starts to stretch out because it's muscular, and it's as if it's like an outside force. It's the only way I can see it. Can't always describe it well, but it's like an outside force is pushing the ankle in this way. So of course it's going to flatten out, and so this doesn't necessarily have to cause foot pain, but the flattened arch is a very good. I suppose it's like a lightning rod. It attracts improper weight bearings. Okay, where are we at? Pretty good. Check mark. Good. So, again, this is what I think. Now, the shoulder area, this chunk right here, again, pretty reasonable. It's not shocking that there's some shoulder problems, because we showed in the previous video again that we've got quite the imbalance here. We've got a real fullness on this side, and we're a little more diminished on this side, and we're a bit, you know, bent in the neck. We're pushed over even. We call that more of a translation. We've got a scapula out. So let's talk about what that does, though, because those are just, you know, things we saw, but let's talk about what effect that could theoretically have. Okay. Oh, yeah, you know, one more thing about this section. You want to fix all that? Fix all that. Got it? Okay. And then understand, you know, if you know how to fix the sacrum, great, then you're good. If you don't know how to fix the sacrum, oof, good luck with that. Take a course. I don't know. All right. And then with the legs, once this short version, once this all gets really wound up, once this gets tight and tight and tight, you got to hit all of it. There's no one single spot. I wish I could tell you there was, but that's not the truth. So good luck. Okay. Last part. So with the right shoulder, when it's turned, they were noticing that there was a crack, and it's in the middle of the right chest. In fact, it's not just like a crack in the shoulder. In fact, I misread it the first time around. Actually, let me get rid of that little dot there, because that's not supposed to be there. I put that in myself. There we go. So there's a cracking sound, and it's generally in the right chest. So let's talk about that, because a stiff neck, that's easy by comparison. So this shoulder, so he spins it, basically does, you know, posterior rotation, doesn't really matter, and the arm ends up somewhere in around here. Now the scapula would come up, of course, you know, can't not do that. Scapula would come up and be like that, and it's doing that spin, and he hears a crack in the front. Again, not complicated. You know, you can try to think of all kinds of crazy things, but it's very easy to understand that there's a sternum, and attached to that sternum we've got cartilage bars. Oops, wrong color. There we go. Blue. It's always blue. It is like it is a bit of a blue. It's hyaline cartilage, so it's a little bit of a bluish color. It's the only thing that's actually drawn accurately in lots of anatomy books color-wise. Nerves are not yellow. Sorry about that. How I wish they were. So there's a sternum, and then the ribs actually attached to these cartilaginous bars, and these cartilage proper rib attachments, there's often just a little bit of a synovial joint in between, or at the very least, I mean, like, it's multiple attachment points. And so when you turn the arm, the pull of the muscles on the ribs. So remember that we talked about this all the way down here. We've got pec major, pec minor, serratus we could have mentioned too, serratus anterior. But these are all coming around the front. So that's like pec major again, pec minor is more from here down, going on the front, of course. But they will attach, at the very least, they will attach into the sternum rib articulation. So there's pec major, and then pec minor is, let me darken that, now we'll make it red. Anyways, pec minor is like rib 3, 4, and 5 I don't think I'm close to being accurate in this image, but I'm just going with it. So there's that. So just looking at just those two muscles, we could throw in the serratus anterior, which is going around more like that, but we'll leave that out for now. It's going to pull and it's going to separate these structures. It's as if it was just pulling kind of straight off that way. And so if there's any movement ability between these, the sternum and the cartilage, and the ribs and the cartilage, it could be that it is exposing that and just cavitating that. So it's slipping. That bone is slipping on that cartilage, or the cartilage is slipping a little bit on that sternal bone. So this is actually a pretty easy one. That one's not shocking. Okay, now what is interesting is the next part of it. That's the crack was whatever, but accompanied by a stiff neck on the right side when that crack happens. Very cool. Very cool. Not for the patient, of course, but for us. So understand that all these muscles, so this is looking a bit muddled, but I'll get rid of what I can here. Understand that these muscles are innervated. They're given nerves by the brachial plexus, so the BP. Not blood pressure, brachial plexus. And those nerves are coming off the neck, actually. It's about C5 to T1, and with the nerve to, there we go, okay, nerve to the pectoral muscles, for instance, it's in around C5 to T1. So there is a matching set of nerves. Now, if this cracks, it goes boom, does a big old something or other there, it's an irritating thing. The rapid slipping of a joint is basically the indication that something is unstable at that point. When your back cracks, it can be nice, but there are times when it's bad. This would be an example of a bad crack, as it is a representation of instability in the body. I don't think anybody wants the ribs to crack in the front of their chest. I hope not. It's really not. It's a gross feeling, and it means like you're very close to the heart. So it's not good to have your ribs move close to the heart. Anyways, bad stimulus, and so then that gets sent back up to the central nervous system. Guess what? So this stuff, all this stuff here, this crack gets sent back and around, and it has an effect on the area of the neck. So that's a C5 to T1, for instance. This is all theoretical, by the way. C5 to T1. And when it reflexes back there, when it sends the information that something bad has happened, it tends to be that whatever is innervated, given nerves by that area, tends to fire off. And that is to create stability. So boom, a bunch of nerve signals shoot out. And that same signal comes back on the efferent end, the motor end, and starts to tense up anything. That includes the pecs, but as well, the C5 to T1 area also sends messages to our good buddies, the scalenes, sends messages to, let's say the splenius capitis and the semispinalis. We're just throwing stuff in there now. And then even the trapezius muscles. So it's not shocking that if we're irritating nerves that are closely associated with the neck, that the reflex, the problem, would be stabilized or compensated for through the same effectors in the same field of nerves. So something cracks in his chest when he moves his arm. The neck goes into a bit of a spasm because it thinks it's being rapidly destabilized. So fixing that, I'm actually going to bring us right back around to kind of our original problem, this area right here, because chances are the rib that is most unstable is the one that's actually being pinched right here, the one that's being most smushed by the two vertebrae in this area. And so it's going to be the unstable one because its articulation, the joint which it rests on, is the least stable as well. And so it could be moving around quite a bit when it gets to the cartilage attachment. It could be moving around like crazy. And that brings us full circle. So to get rid of, let's say theoretically, to get rid of that, we have to get rid of that. And we have to really fix a whole bunch of stuff. Again, this is all just a guess, but hopefully it was an enjoyable guess. And you had a good time. Again, we've been Simple Lines Anatomy. We have all that social media stuff. We even have an app that covers a lot of the bones and muscles that were in this explanation. And, if you get a chance, if you're not hanging out with friends at all, maybe check us out.